Good evening to everyone who's joining us via Facebook and YouTube. We know you are just loading in, and we are waiting just a couple minutes to go live so that we give everyone who has signed up this evening an opportunity to settle in. We will start in about 20 seconds. I see those numbers growing. I'm going to wait about another 10 seconds, and then we'll start. Thank you for your patience. Okay, let's get started. Good evening, everyone. My name is Anne Garst-Taylor, and I am the Director of Community Engagement for AIM Melanoma. We are the parent company for AIM at Skin Cancer. We are so delighted this evening to be co-hosting this symposium with the Lurie Cancer Center. We want to thank, of course, Dr. Wayne for being our moderator and all of our panelists for their collective wisdom. We know that you're going to have questions for our panelists this evening, and so we have worked that into our agenda. Right before we get to our shared panel, we will have a short period where we'll take live questions from our viewers. The way that you will be able to do that is if you are joining us via Zoom, we invite you to look at the bottom of your screen, and you will see a number of icons at the bottom, and one of them says Q&A. That is where you'll put questions for the panelists. If you are joining us via Facebook or YouTube, then what you will need to do is just put your questions inside the comments, and we will magically transfer them over to Zoom. So thank you so much for joining us. I am now giving the floor to Dr. Wayne to open up our symposium.
Thank you, Anne, and thank you to AIM, who has been a great partner to us over the many years, and has helped us put on other educational symposia, and also, funds our melanoma tumor bank. So thank you for all that you do for us and for our patients. I also wanted to thank you for giving us the opportunity for our group at Northwestern to share our expertise in the area of non-melanoma skin cancers. We're going to start out tonight with a session on cutaneous squamous cell cancers and basal cell cancers. We're then going to move into a second session on Merkel cell cancers. And finally, we'll talk a little bit about clinical trials in non-melanoma skin cancers. We'll then open up the floor to some questions before we then kind of share with you kind of what a tumor board presentation might be at our institution and how we manage patients collectively. So I think you're really going to enjoy this. We really have some wonderful panelists and speakers tonight. And so I'm going to hand off. The first session is going to start with Dr. Lu Chen, one of our experienced dermatologists, who's going to talk about risk factors and diagnosis of cutaneous squamous cell and basal cell carcinomas. Lu, the floor is yours.
Thanks so much for the introduction, Jeff, and thanks again. It's my pleasure to speak to you all this evening about cutaneous squamous cell skin cancers and basal cell skin cancers. So I'll be focusing on risk factors and diagnosis for these cancers. Next slide, please. So both come from keratinocytes, which are the primary type of cell in the outermost layer of skin, or the epidermis. Next slide, please. So these keratinocyte cancers are the most common cancers worldwide and are more common than all the other cancers combined. The lifetime risk of one of these cancers in the US is about 20%, which is approximately 1 in 5 Americans. And the incidence rate has been increasing over the past few decades, predicted to continue to rise. Next slide, please. So what are the risk factors for basal cell skin cancers, BCCs? Older patients, men, people who have fair skin. Basal cell skin cancers are less common in darker skin because the melanin, which is what gives your skin color, protects your cells from the sun. So it turns out that adamantium doesn't protect your skin from the sun, neither does the force. So celebrities are just like you and me. They get skin cancer too. We are big fans of Vibram hats, though that's something that we do love for our sun protection. Next slide, please. So as I alluded to, BCCs are caused by sun exposure of UV damage, especially intermittent and intense sun exposure. So that could be from tanning bed use, outdoor activities like tennis or golf, sunburns, especially in childhood as opposed to adulthood, or if you've had radiation in the past, usually many years ago, for a different kind of cancer. Next slide, please. So what do BCCs look like? So classically, they're pink shiny bumps that bleed. They can have a sore in the center, such as on the forehead here or near the eye. They can be skin-colored bumps or pink scar-like areas with a little depression in the center. Next slide, please. They can have color and be more brown. They can look like sores that don't heal, like on the ear or the arm here, or they can look like pink scaly areas like on this patient's temple or on the shoulder. Next slide, please. So let's say you have a spot that looks like this and you come see a dermatologist. How do we diagnose skin cancers? So we'll look at your skin. We might use a device like this called a dermatoscope, which helps us see deeper into the skin and can help us spot early signs of skin cancer. Next slide, please. And when we find something suspicious, we'll recommend a skin biopsy to confirm the diagnosis. So we'll clean off the area, numb it up. Next slide, please. We'll either take a thin layer of skin around and underneath the spot, like a little scrape, or next slide, please. We might use a tool like this, kind of like a little cookie cutter tool, to take a cylindrical piece of skin. And next slide, we'll put in a couple of stitches. Next slide, please. So we'll send you home with a bandage, and we will send the specimen that we just collected to the lab. Next slide, please. And they'll process the tissue and make these slides. And then someone like me, who also specializes in reading slides, issues a pathology report with the final diagnosis. Next slide, please. So for example, some of these pink spots that we talked about, this is what you might see under the microscope. This is the classic look of a basal cell cancer under the microscope, these bluish areas with clearing around it. So basal cell skin cancers are usually slow growing. They stay in one place, can get bigger, destroy normal skin. They can bleed and become bothersome. They usually don't go anywhere else in the body or metastasize unless they're neglected for many years. So moving on to a skin cancer that can be a bit more aggressive than a BCC, it takes us to our cutaneous squamous cell carcinomas, CSCCs. Next slide, please. The risk factors for these skin cancers can be similar to that of BCCs, so sun exposure, tanning beds, similar to BCCs. Can also have other environmental exposures, for example, exposure to arsenic, which you can find, for example, sometimes in well water, other chemicals that you can find, for example, through exposure to coal tars. Another thing that increases your risk of CSCCs is if you have a weakened immune system. So this can be if you have had a solid organ transplant, for example, heart transplant, kidney transplant, you take medications that suppress your immune system. Or if you have leukemia or lymphoma and you have a weaker immune system than normal. If you have a chronic wound or chronic inflammation, that can also lead to SCCs, or infections like HPV, human papillomavirus, which is the wart virus. There are certain strains that are more likely to promote skin cancers. Next slide, please. So what do CSCCs look like? So here on the top left, a red scaly patch, this is the classic look of a squamous cell carcinoma in site 2, which is the earliest stage of CSCC. It's just in the top layer of skin in the epidermis. These skin cancers also have color. They can look brown, almost like an age spot, like here on the lower left. As they invade into the next layer of skin, they become more raised. They can look like a red scaly bump, such as here on the ear or on the nose. Next slide, please. These skin cancers can get very scaly. So for example, here on the top left, you can almost look like you start developing a really scaly spot that almost looks like an animal horn. They can be crusted lesions like this one on the lower left on the lip, can be on the scalp. They can affect the nails, for instance, on the top right. Sometimes this, they can look like warts, and maybe that's how it started, but you can also get squamous cell skin cancers around the nails. You can also get them in areas you see less sun as well, such as under the underwear. Next slide, please. So if you biopsy a spot, a squamous cell, a CSCC, you might see something like this on the slide. So here in the center, you have these pink, really atypical, abnormal looking cells, these masses of these cells. And you can see this tumor in particular is very large and very deep. Next slide, please. And that those are higher risk features that we see under the microscope. Other things we can look for are what's called poorly differentiated pathology. So if something is well differentiated, that means it tries to look like or mimics normal skin, where if it's poorly differentiated, it doesn't do so, and it's usually, that's associated with worse behavior, bad behavior. Other high-risk features are if the tumor involves nerves or grows into fat or bone. So if you have a SCC with one or more of these features, will have a higher stage. And the staging system is something that we use and when we start to think about prognosis or treatments for these tumors. So, these cancers are much easier to treat when they're small. Next slide, please. So what can we do to catch them early? Well, we recommend checking your skin. So you can check your skin at home. It's called a self-skin check, or you can come see, have a total body skin check with a board certified dermatologist, especially if you're a patient at higher risk. That's something we recommend. Next slide, please. And how do you prepare for a total body skin check, and what do you expect? So we'll have you change into a gown. The visit will be focused on your skin exam and kind of a thorough check from head to toe, looking for anything suspicious for skin cancer. So, do wear your hair loose so we can check your scalp. Spray tans are okay. Don't wear any nail polish so we can examine the nails. Don't wear makeup or bring makeup remover so we can examine the face. And make sure we take a very good look all over. And next slide, please. Some resources that can be helpful. AAD.org, which is the website of our American Academy of Dermatology, our professional society, has a skin cancer resource center. They have a variety of resources, including how to perform a self-skin exam. And AIM at Skin Cancer Foundation is also a great resource, and thanks so much to them for helping run this great event. And that's all I have. Thanks so much.
Lou, thank you. Really a nice introduction and a lot to digest there. We'll now pass the baton to Dr. Murad Alam, who's going to fill us in on Mohs surgery, which is a modality that's commonly used to treat non-melanoma skin cancers. Murad?
Thank you. Appreciate it. Again, it's a pleasure to be here. Thank you so much for having me, Jeff. So I'm going to talk mostly about Mohs, and since Dr. Chen has already done a great job of talking about squamous cell and basal cell, much less about that. Next slide, please. So just again to review in literally 2 slides, what is basal cell? It's the most common cancer and also the most common skin cancer. It also often looks shiny, and sometimes it looks like a non-healing or irritated patch of skin, usually on sun-exposed areas, head, neck, chest, backs of arms sometimes. And unlike other forms of skin cancer, it usually grows just where it's at and doesn't spread to other places. Next slide, please. Squamous cell carcinoma is the second most common kind of skin cancer. There are about 5 million basal cells a year, maybe 500,000 squamous cells a year. It comes from sometimes by itself and sometimes from these other scaly, rough things that you might have on your face called actinic keratoses that are sandpaper-like, a little red, but often easier to feel as rough areas than to see. It's often, as Dr. Luchan said, very scaly, and that distinguishes it from the pinker and smoother pearl-like basal cell. It can occur on sun-exposed areas and also in other places, and this does have small chance of spreading to other places. Next slide. Now, there are a variety of treatment options for skin cancer. You can freeze them sometimes when they're early or when they're precancerous. For very elderly people who can't deal with surgery, radiation therapy is a possibility, although, of course, radiation also causes cancer and skin cancer, so we hold that in reserve. Surgical excision is frequently done, meaning you just remove the skin cancer by estimating where it ends. And you often do this when it's on the body, but not on the face. And similarly, curettage and electrodesiccation, that means heating and scraping it off. But if it's on the face or head or neck, or it's a place where, like the hands or feet or the genitalia, where it's going to potentially cause some disfigurement or functional impediment, if it's a really large skin cancer or large surgery, then you might do Mohs surgery. Next slide. Now, Mohs surgery is the method that has the highest cure rate for taking out skin cancers. And why it does this is because you look very carefully around the entire edge of the skin cancer microscopically to make sure it's all gone. So that's the good news. You get the whole thing out. The other good news is that because you're being so careful and you're only taking out the cancer, you can spare the healthy tissue. So you kind of get out all of the cancer, but nothing but the cancer. So you have a high cure rate, but also the smallest space possible, so that when you put it back together, hopefully you have a smaller scar and less of an issue. When do you do Mohs? As I mentioned earlier, when the tumor is in a critical location, whether it's going to be disfiguring potentially, and like your nose or your forehead or your eyebrow, or if it's in a place where you could have functional loss, like it's near your eye or near your mouth, you need to be able to see and talk. If the tumor is recurrent, meaning it was removed before, but it came back, that means it might be funny looking underneath the skin, and you might need microscopic assessment to make sure you get it out. If the tumor has ill-defined margins, what that means is it's not easily possible to see where the tumor begins and ends. You're not really sure, so you need to check it. Or if the tumor is very large, and by very large, we mean more than about 1 inch in diameter, or aggressive. It's a kind, like Dr. Luchan said, that's poorly differentiated. You're really worried it might do something else that's problematic. Next slide. So I'm just going to go through quickly the steps of Mohs surgery. So first you find where the tumor is, and then you debulk it. Debulk means you take out what you can see. You can take it out with a scalpel, or you can take it out with a curette, which is this round, scrapey instrument that's seen over here. Next slide. Then once you do that, you take a little margin around the area where the skin cancer was to try to get the whole thing out. And this could be 1, 2, or 3 millimeters, depending on where the tumor is. If it's on the nose, you might take a really tiny 0.5 or 1 millimeter margin. You bevel it, which means you kind of take it in a certain way that makes it easier to process the tissue in the lab. Next slide. And then you make some marks so you know where it is, because later on you might have to come back to take out some additional tumor. So if you don't know where 3 o'clock and 9 o'clock and 12 o'clock are, you'll be confused about where you need to go back. Next slide. Then you take out the tissue, which is both where the cancer was plus the edge you took around it. Next slide. And then you map this out. So you may put this on a map that shows where exactly on the body it came out. You cut this into pieces so it's easier to process microscopically. One is 12 to 3 o'clock, 3 to 6 o'clock, 6 to 9, 9 to 12, that sort of thing. Next slide. And then each of those pieces, you put ink on different sides of it so you know which side is which. And then you put it into this medium, which is liquid that freezes so that you can make it solidified. Next slide. And when it's solidified like this, kind of almost like an ancient insect frozen in amber, then you slide this very sharp blade along it and cut very, very tiny, thin slices of this. Next slide. And these thin slices are put on glass slides, which go through a stainer, because right when you start, the tissue is transparent. You can't see anything, but use blue stain and red stain so you can see the different parts of what's going on in the skin. And then you look at it under the microscope. This picture of the old guy is not me. This is actually Frederick Mohs, the guy who invented the procedure. Next slide. And then once you know what's going on and the slide and you've looked at it under the microscope, you might need to go back if there's some positivity, as in this case in one of the sections. You can see section 1 has a little smudge. That's where there's still some cancer. You go back to the patient. Next slide. You go back to exactly just that one area where there's still a little bit of tumor left. You take another little sliver there. Next slide. And then you check it again until all of the edges are completely clear and the underside is completely clear of tumor. Next slide. And then you figure out a way to help it heal. And there are a variety of different ways you can help it heal. I'm just going to show you some examples. This is second intention healing. That means sometimes you don't even have to sew it up. In places like the corner of the nose or inside the ear, you can just leave it alone. It heals really beautifully by itself. That's called second intention. Next slide. Sometimes it's a little bit more complicated, but you can literally pull the skin together like a curtain and just zip it up, and it heals quite nicely. As in this case, that's called a linear repair or a linear closure. Next slide. Sometimes you can't just pull it together, like on the nose, for instance, because the nose will become all smushed and you won't be able to breathe correctly, or it'll move to one side or the other. So you might need to do what's called a local flap, move some skin from a place where there is extra skin while keeping the blood supply intact and filling the space where you need additional skin. Next slide. Sometimes you just can't find a place to do that from, so then you do a skin graft, meaning you take skin from somewhere else on the body, maybe behind the ear, in front of the ear, or the forehead, and then you put it into where you need to. This sounds very easy, and it's pretty straightforward. The problem is with this, sometimes the color and texture doesn't match. It looks a little bit like a patchwork quilt. So you'd generally rather do a linear repair or a flap than a graft unless you have to. But sometimes if it's a small area, the grafts work out well. Next slide. And then sometimes you need multiple kinds of things. So here you have a composite graft. You have to move skin and cartilage because you want to both fix the skin, but you also know the cartilage is missing. You don't want the nose to collapse when you breathe in. Next slide. After surgery and after the repair, you get some instructions, usually in Mohs, about how to change bandages, clean the site, use medications. And for a little while afterwards, you might not do a lot of intense exercise to let the wound heal. If you have stitches, we'll see you back to take those out. And then after that, there are a variety of ways to treat the scar with a variety of methods, including lasers, to try to make them less red and blend better. Next slide. That's it. Thank you so much.
Murad, thank you. That was really a wonderful presentation, and gives us a little window into what you guys do every day. So thank you. Our next speaker is Dr. Caitlin Steppen from the Division of Otolaryngology and Head and Neck Surgery. And Caitlin's going to talk to us about the surgical options when something more than Mohs is indicated. Caitlin?
Hi, thank you so much for having me here today. So today I will be discussing surgical management beyond Mohs of the cutaneous squamous cell carcinoma and basal cell carcinoma. Next, please. We'll review some of the indications for surgical treatment, as well as how we would treat the primary tumor and lymph nodes when those might be involved. We'll review some of our reconstructive options, and finally, we'll finish with some real patient examples. Next, please. And just to mention, you know, I'm a head and neck surgeon, so I will be focusing on the head and neck, but many of these surgical principles are more broadly applicable to other sites of the body. So Dr. Alam just gave a really beautiful overview of Mohs surgery and highlighted how in many cases it's our preferred approach. However, there are some cases where Mohs may not be feasible in the head and neck. This could be due to the location, for instance, areas difficult to access, such as the ear canal, or due to the size or extent of the lesion. For instance, those tumors that get really large and invade deeper tissues, such as the surrounding muscle or bone. In these cases, we instead perform what's called a wide local excision. So we mark out our margins around the lesion and excise the whole thing, and then analyze the margins after it's excised. Depending on the particular lesion, recommended margins can range anywhere from 5 millimeters to a centimeter, or about the width of my pinky. A carcinoma of the skin, next please, can also spread to nearby lymph nodes. In particular, this can happen with higher risk cutaneous squamous cell carcinomas. As Dr. Alam mentioned, spread to lymph nodes is quite rare in basal cell carcinomas. So when we have a high-risk lesion, we'll often get imaging to evaluate for abnormal-looking lymph nodes. In general, if we know we have spread to the lymph nodes, we'll perform a lymph node dissection where we remove the positive lymph nodes as well as any adjacent nodes in the high-risk drainage areas. Another option to manage lymph nodes is called a sentinel lymph node biopsy. A sentinel lymph node is the first lymph node to which cancer cells are most likely to spread from a primary tumor. So a sentinel node biopsy is really still an evolving practice for this type of cancer, but in general, it can be considered for cases of very high-risk cutaneous squamous cell carcinoma, particularly those that are recurrent or have other multiple risk factors. Next slide, please. So everything we remove at the time of surgery is set for pathology, and then the cancer is risk stratified based on various characteristics seen under the microscope. This helps determine if additional treatment is needed. Oftentimes, in the cases I'm seeing, this would be radiation. Next slide, please. So the next big component of surgical management is reconstruction, and Dr. Alam talked on several of the reconstructive options, and so I'll kind of highlight some of the larger options for our larger defects. But he mentioned healing by secondary intention, primary closure, skin grafting. We also have several types of flaps that we can use for reconstruction for larger defects. Next slide, please. We have local flaps, which is where we rotate immediately adjacent tissue into the defect. We have regional flaps, which is where you use tissue from nearby but not immediately adjacent and rotate that into the defect, such as there on the top right, rotating skin from the forehead to cover a nasal defect. In both these local and regional flaps, the tissue or flap remains pedicled to its blood supply. And then finally, for larger defects, down there at the bottom is pictured a free flap. A free flap is where you use remote donor tissue, such as from the arm or the leg, for reconstruction. And you connect the blood vessels that supply the arm or the leg tissue to blood vessels in the neck to provide a healthy vascularized flap reconstruction. Next slide, please. So finally, let's get to some real patient case examples to highlight some of these reconstructive options. And I just want to give a big thank you to Dr. Wong, one of our facial plastics colleagues, who does a lot of Mohs closures, who was kind enough to share some of his lovely photos of local reconstruction cases here. So this is a local flap. You can see, the skin cancer was removed there on the forehead and is in the shape of an O. By making some incisions on either side, we can advance the tissue on either side to create what looks like an H-type closure. And some of those lines are hidden in kind of the natural skin creases of the skin. And you can see there on the top 7 days post-op and then 7 months post-op, you can have a really nice cosmetic result. Next, please. Oh, I'm sorry. That was for that slide. Thank you. Can you go one more?
Okay, something's supposed to come up on this.
No, hit the next one if you don't mind. Sorry about that.
Oh, this one?
We'll go here. I think we skipped a slide there. I apologize. So, yep, one more. That's the O to H, and then we'll go to the next one. Thank you. So this is an example of a large lip defect. You can see the skin cancer has been removed here. And in this case, next, please. Sometimes, as you can see here, it's actually helpful to remove even more of that tissue. So this was a partial thickness defect. We actually removed the entire thickness of the defect so that we could then rotate full thickness lip together and close it in a straight line. Next, please. And this is immediately after closure. Next. and then 6 months post-op. Next, please. This is just an example of what we call cervical facial advancement flap. So you can see a decently sized cutaneous cancer on the temple there, marked out with its margins. Once it's excised, you have a fairly large defect. So we actually make an incision back down in front of the ear and down onto the neck so that we can then rotate and mobilize all of that facial and neck tissue up. Next, please. To fill in that defect. And you can see this is what it looks like immediately after closure. Next. And then 1 week post-op, and finally 3 months post-op. Next, please. And on a much larger level, this will be an example of a total nasal recon. So this gentleman had a very advanced skin cancer, requiring the removal of his entire nose. He's actually been disease-free for over 2 years, but doesn't like his nasal prosthetic, so instead opted for total nasal reconstruction. This is actually a case I just did with Dr. Wong the other week. In this type of reconstruction, you have to reconstruct the nose in 3 layers. So the internal lining, the bony and cartilaginous framework that gives the nose its shape and integrity, and finally the external skin. Next, please. So for the internal lining, we utilize the radial forearm free flap that's borrowing tissue from the arm as well as its blood vessels. And then to reconstruct the framework, we take a bone and cartilage graft from the rib, as you can see there. Next. Next slide, please. Oh, I think one back. There. One back. There we go. Perfect. So this is insetting the flap internal nasal lining. You can actually see his tattoos, but those end up on the inside, so you don't see them. And then plating that bone to reconstruct the nasal dorsum. Next, please. So now we need the skin envelope externally, and you can see for that we used a paramedium forehead flap. So this is what it all looks like 1 week post-op. But this is just the first step of many steps. So at this point, the priority is just getting that healthy vascularized tissue in, but you can see the flap appears extremely large. So after things have settled down a bit over the next several weeks to months, he will actually go back for several smaller procedures to refine the flap to make it more similar to a native nose. Next, please. This next example is a very large cancer involving the scalp extending down into the bone. And you can see it there marked out with our margins. It's resected with the help of neurosurgery, who actually helps take the some of the skull bone. And then in order to reconstruct this, we need a big reconstruction. So in this case, we utilize a thigh free flap. Next, please. And you can see we harvest that skin and soft tissue from the thigh and inset it into the scalp and actually connect those blood vessels by making an incision down along his face to connecting it to blood vessels in the face. Next, please. And then lastly here, we just have a total lower lip defect reconstructed with a radial forearm. So you can see we have lots of options and can get creative with some of these bigger lesions. Next, please. And so just to summarize, wide local excision is often recommended when Mohs is not feasible, either due to location or the extent and nature of disease. More aggressive skin cancers may spread to nearby lymph nodes. In some cases, we can consider a sentinel lymph node biopsy, while clinically positive nodes are typically removed. Everything we remove, we send for pathology, and this can help determine next steps. And we have a wide variety of reconstructive options. And in general, we try to use the simplest technique to achieve the optimal outcome. And that's all I have for you. Thank you.
Caitlin, wow, that was quite the presentation. Thank you for sharing those cases with us. And we'll have a few minutes for some questions. But why don't we turn now to Dr. Sue Chandra, who's one of our outstanding medical oncologist that helps us with our complex cutaneous malignancies.
Thanks, Jeff. Hi, everybody. Thanks for joining us this evening. There was a slight change to the agenda schedule. So today I'll be talking about systemic or whole body therapies that we have available to us for cutaneous squamous cell carcinoma, which I might call CSCC, and basal cell carcinoma, which I might call BCC. Next slide, please. So I'll be really focusing on cutaneous squamous cell as well as basal cell carcinoma in my portion of the talk. And then Dr. Jeff Sossman later is going to focus a little bit on Merkel cell carcinoma. Next slide, please. So when does medical oncology get involved? Usually, although it might be different for different cancers, in the non-melanoma skin cancer world, we usually get involved with more advanced stage scenarios. So when a person may have a BCC or a CSCC that is not amenable to further surgery and or radiation, at that time, systemic or whole body cancer therapy may be indicated. Next slide, please. So we have a number of therapies that are already FDA approved in these two cancers. For CSCC, or cutaneous squamous cell carcinoma, we have the anti-PD-1 antibodies that I'll get into a little bit more detail, namely cemiplimab and pembrolizumab. We also have targeted therapies, although it's an intravenous drug, cetuximab and our traditional chemotherapy. For BCC, or basal cell carcinoma, we have pills known as hedgehog inhibitors that I'll explain in just a moment, namely sonitigib and vismodegib. And we also have anti-PD-1 antibody, specifically cemiplimab. So these are the ones that are FDA approved for these two types of cancers. Next slide. So let's talk about what these hard to pronounce drugs, these anti-PD-1 antibodies, how they work. So examples of this that are approved in non-melanoma skin cancers are cemiplimab and pembrolizumab. So the way these work is here depicted in blue are the T cells. Now this T cell has been trained to recognize a piece of the non-melanoma skin cancer. That piece known as a neoantigen, here depicted, I believe, in this kind of orangey little part of the cartoon. That neoantigen is then recognized so the T cell recognizes that neoantigen and then basically goes into the tumor microenvironment to find similar cancer cells to kill it. Now, what happens traditionally is that T cell automatically becomes shut down by the natural human immune system, which then makes it a dysfunctional T cell, which is unable to then kill cancer. And what these PD-1 antibodies do is they basically activate that T cell so they can remain active and continue to kill the cancer cell. Now, we don't get something for nothing. So when we do that, it can cause a whole host of side effects that we can certainly talk about more if we have some time. Next slide, please. So next, I'll be talking about hedgehog inhibitors. These are specifically only approved in basal cell carcinoma. The previous slide that was approved, those categories of drugs are approved in basal cell carcinoma, cutaneous squamous cell, and Merkel cell, but sonic hedgehog inhibitors are only approved in basal cell carcinomas. And the way this works is in a basal cell itself, this signaling pathway with the sonic hedgehog protein, the patch protein, the smoothened protein. In general, this signaling pathway can be active, leading to basal cell growth. And so the way these hedgehog inhibitors work is they basically block the protein, the sonic hedgehog protein, which then creates a downstream effect of blocking the signaling inside the cell. thereby causing basal cell death. So that's how these hedgehog inhibitors work. Next slide. So in cutaneous squamous cell carcinoma, next slide, there's some risk factors for recurrence. And these are what we think about in our team, as well as in medical oncology specifically. So size, location, is it a primary? Is it a brand new spot, or is this like a recurrent spot? Has this spot undergone prior radiation? Are there pathologic features that Dr. Chen had spoken about that make it a little bit more higher risk? And then furthermore, is the patient immunocompromised? Next slide, please. So if a person has unresectable metastatic cutaneous squamous cell carcinoma, in the past, we only had drugs like chemotherapy or cetuximab to offer, but now we actually have these anti-PD-1 drugs that I'd previously alluded to that have really revolutionized how we treat these cancers. Now, when we talk about these drugs, I just wanted to give you a brief idea of how we think about the data. So this data, this box on the top is called a waterfall plot. And each of these bars represents a particular person's tumor response. And all the downward deflections reflect tumor shrinkage. So the more downward deflections there are, the more this drug seems to be effective in causing tumor shrinkage. This bottom part of the slide on the bottom left shows derivative response. So in general, what this is showing is these therapies not only cause tumor regression in about 50% of patients, that's what the ORR means, objective response rate, but they're also long-standing, they're durable, which is what we want to see in our patients. And on the right, you see some pictorial, some pictures depicting these profound responses. Next slide, please. This is again showing what I just talked about. In addition, it's showing that after cemiplimab, this particular person on the right not only had tumor on his anterior or front part of his neck and kind of chest, he also had tumor in his lungs. Next slide, please. And basically, one more. Basically, the cemiplimab, the anti-PD-1 drug, caused a complete response visibly and about a 90% response in the lungs. So these can work profoundly well. Again, in this slide, you're seeing some not only pictures depicting actual posterior auricular or behind the ear masses, but you're also seeing the corresponding radiographic imaging on CT that's showing shrinkage of that mass as we visibly see disappearance of the mass. Next slide, please. So another paradigm, which is not FDA approved, but it's changing how we're starting to think of how to treat these cancers, is the neoadjuvant setting. So what that means is before someone goes to surgery with, for example, Dr. Alam or Dr. Stepan or Dr. Wayne, we can potentially give them these therapies before surgery to try to shrink the tumor. So we give a limited number of doses, and then at the time of surgery, hopefully the point is that it will improve their surgical outcomes. So because this is not FDA approved, we do this on a clinical trial, and we actually have clinical trials looking at this here at Northwestern, but this is really shown to be an effective way of shrinking tumor prior to taking someone to surgery. Next slide, please. Next, we'll talk about basal cell. Next slide, please. So the risk factors for basal cell are very similar to the ones I just mentioned for cutaneous squamous cell carcinoma. Next slide, please. So again, here, remember, in basal cell carcinoma, not only immunotherapy is approved, but these hedgehog inhibitors, which are pills, are also approved therapies. And here, if you recall what I talked about, the waterfall plot, you see that most of the patients had shrinkage of tumor depicted by these downward deflections in this waterfall plot. Again, each bar is a particular person's response. So whether we try sunitinib in a person or vismodegib, the response rates can be quite significant, and they can last somewhere between maybe a year to 2 years. Next slide, please. Now, in the event that those therapies don't work, or if a person can't tolerate those therapies, then we go to anti-PD-1, specifically cemiplimab, which is also shown to have a benefit in advanced basal cell carcinoma. But usually we only use this after someone has already tried a hedgehog inhibitor. That's how it's FDA approved to be used. Next slide, please. So these are some, I thought, some profoundly responsive patients with cemiplimab really shrinking and in these instances actually causing disappearance of their basal cell carcinoma. Next slide, please. So things to consider is we absolutely have more effective systemic or whole body therapy options in these cancers. One thing that's very important, as you guys have already probably gathered from our panel, is that it needs a very multidisciplinary team discussion, because the thought is, does medical oncology need to step in sooner, perhaps in a neoadjuvant setting, or should the person go to surgery right away? When does radiation play a role? Pathology is a huge issue, so tissue is the issue. We always say in medical oncology, we absolutely want people like Dr. Chen commenting on the exact pathologic features so we can figure out how risky a person's tumor might be. And then, of course, we have to help manage toxicities in a safe manner. We have to look at people in which these drugs aren't working. What do we offer them? And then we also have to think of special populations in which a person might be immunocompromised, such as people who have a solid organ transplant or other immunocompromised states. And then these traditional therapies may have to be considered a lot more thoughtfully. Thanks for your attention.
Sue, thank you for that wonderful talk. And you know, I hope as you sit at home, you wonder, well, which of these things do we use for our patients with this? Do we use big surgeries? Do we use Mohs? Do we use medical therapies? And I think the answer is we use all of them. And so as Sue pointed out, it really is a case where, you know, we have these multidisciplinary consultations and talk about patients and try to individualize patient treatment to all the bullets in our armamentarium. So we have actually about 4 minutes. We're about 4 minutes ahead of schedule. I don't know if there are any, and if any comments have come in or questions have come in, we can probably take a minute and throw it out to our panelists or our individual panelists if anyone has any questions at this point. If not, we can save them all to the end.
We did have one question, and I'm trying to find. I sent it to be put into the Q&A. Let's see. The question says, my squamous cell skin cancer is very painful. Will that pain get better if the tumor shrinks? If not, are there other pain management options?
I don't know, Murad or Caitlin, if you want to take that one, or Sue, you know, do you want to talk about that with some of maybe what you've seen in some of the larger cases that you've treated neoadjuvantly or definitively with medical therapy?
Sure, I can certainly share some thoughts, and I'd love to hear what my colleagues have to say as well. I mean, so cutaneous squamous cell carcinoma is actually one of the more painful skin cancers. So I'm so sorry to hear that it is causing you a lot of pain. I think one thing to keep in mind is if we can use effective therapies to shrink the tumor, that should help alleviate your pain. And in the meantime, I hope that your team can kind of, in a comprehensive manner, be able to kind of help manage your pain in the interim. And we have a lot of options to consider to keep you as comfortable as possible, pain-wise, while the treatment hopefully takes its effect.
Yeah, I would agree with that completely. It's Murad. Basically, I think whatever size the tumor is, even if it's a more modest sized tumor that can be treated by Mohs surgery, it's definitely the case that the tumor itself can cause a certain amount of discomfort. So whether you remove the tumor surgically, or whether you use medications to shrink it down, I think it's almost always the case that managing it in some way will diminish the discomfort.
Caitlin, anything to add?
I would completely agree with all of those comments. That is, yeah.
So, Murad, since you're on, there's a couple other questions in the Q&A which we can talk about. I think there's one that we'll save for a little later after Dr. Chana talks about new therapies and trials at the end. But the two questions that revolve around Mohs. One is, I had a Mohs surgery on my scalp and the hair is not growing back. Any suggestions to make that happen? And the second one, again, I think you can probably address these both, is I've had Mohs countless times and the healing is very disruptive to an active lifestyle. Another dermatologist has recommended scrape and burn. Is this as effective as Mohs? So Murad, if you want to try to tackle those.
I think scalp surgeries for Mohs are always challenging because there's hair there. And even beyond the area of the skin that you take out, when it's sewn up tightly, sometimes that can cause injury to the surrounding hair follicle. So one way to do it is to make sure you loosen up the scalp when you're sewing it up. Also keep in mind that sometimes right after surgery, the stress of surgery makes the hair fall out. But sometimes 3 to 6 months later, it comes back. If it still doesn't come back 3 to 6 months later, you can try to remove the scar, loosen the skin, and then hopefully it'll come back. With regard to burning and scraping, that's a very reasonable approach, especially for thin squamous cell or basal cell cancers that are not on the face, neck, genital area, hands, or feet. If they're on your body, your trunk, your abdomen, your thigh, that's a very reasonable way. It leaves a little white patch, but then like you said, it means you don't have to stop exercising. You can do everything you want.
Thank you, Murad. All right, we're right on time at 6:50, and we're gonna shift gears and we're gonna move from two very, very common skin cancers, squamous cell and basal cell, to now one of the more rare skin cancers that we treat, Merkel cell carcinoma. So could you please bring up my slides? Okay, so as I mentioned, we're going to talk a little bit about Merkel cell carcinoma and focus on initial diagnosis and management. Next slide, please. Oops, go back one, please. All right. So what is Merkel cell carcinoma? Well, it's a rare and aggressive cutaneous neuroendocrine tumor. By neuroendocrine, we mean originating from the neural cells in the skin, as opposed to, say, melanoma, which arises from the pigmented cells, or say the basal cell carcinomas, which arise from basal cells, or squamous cell carcinomas. It primarily affects sun-exposed skin. So we see this often in the head and neck region or in the hands and forearms of older individuals. And diagnosis has risen interestingly fivefold in the last 30 years. And from 2000 to 2013, Merkel cell carcinomas increased 95%. And the incidence is expected to rise even more, up to 2,500 cases per year, from up to about 2,500 cases per year to 3,250 cases per year by 2025. Next slide, please. And this is a schematic of the skin, just to kind of give you an idea of where these nerve cells that he's talking about. So the Merkel cells lie just beneath the epidermis and above the dermis. And you can see it there on the image, the expanded image on the left. Next slide, please. Risk factors for Merkel cell carcinoma, somewhat similar to other skin cancers. UV radiation exposure probably accounts for about 20% of all Merkel cell carcinomas. And interestingly, and more recently, a virus, what's called the Merkel cell polyoma virus, has been thought to be etiologic in about 80% of cases. Again, this tends to affect older individuals, Caucasian men being the primary highest risk group, and also affects our immunosuppressed patients, so our solid organ transplant recipients and patients with uncontrolled HIV. Now, interestingly, we've seen really a vast increase in all these cancers, especially in our organ transplant population, and they present us with some unique challenges. But I think the main point there is if you have someone that's had an organ transplant and you are immunosuppressed, you should be in the hands of a good dermatologist and be seen regularly. And I know at our institution that's they not only get examined before they even get a transplant, they're examined quite frequently thereafter. Next slide, please. So in medicine, we always like mnemonics. It helps us remember all the different things that we have to remember. And so for Merkel Cell Carcinoma, it's AEIOU. This came from a paper in 2008 in the Archives of Dermatology. Basically, A is asymptomatic. So these are painless lesions as opposed to some of those squamous cell carcinomas that you just heard about. They rapidly enlarge. That's E for enlarging. They occur in immunosuppressed individuals. That's the I. Older patients greater than 50 is the O, and U seem to be associated with ultraviolet radiation. When one of these lesions is seen, someone like Dr. Chen or Dr. Alam will do a biopsy, either a shave biopsy or a punch biopsy. And what you see on H&E, which is our basic staining, are these bright blue sheets of cells. And on immunohistochemistry, this is kind of special stains that highlight certain cells for us. They're CK positive and TIF1 negative. So that's the CK positive cells, are those brown ones that you see, and this secures the diagnosis. Next slide, please. So now you've been diagnosed with Merkel cell carcinoma, and that's when you usually are referred to someone like me or Dr. Steppen. You're going to get a complete skin exam if that wasn't done already, and usually we'll do it anyways because we don't trust anyone but ourselves. We also do a thorough lymph node examination, and if there's any question about nodal disease, in other words, enlarged lymph nodes, then we'll usually follow that with cross-sectional imaging, such as a CT scan, an MRI, or a PET-CT. And interestingly, about 12% of patients with suspicious findings on their H&P, in other words, something unusual you pick up on physical exam or by talking to the patient, will have what we call a CULT, or not previously unidentified metastatic disease. This is a patient who presented actually with a palpable inguinal lymph node as one of the earliest manifestations of Merkel cell carcinoma. So we don't necessarily image everyone right off the bat, but probably somewhere in your treatment course, you're going to get either a CT scan of the neck, chest, abdomen, pelvis, or a PET scan. Next slide, please. These are what we call our NCCN guidelines, and at Northwestern, we're very proud that we were a founding member, actually, of the NCCN, which was a small consortium of what we like to think of the best cancer centers across the world, across the country. But now has grown, and I think it's almost up to about 30 members, including places like MD Anderson, where I trained, Sloan Kettering, Duke, Stanford, Michigan. And, basically any place you would want to be treated has someone who comes to the table, and we have individual panels, and a number of the people on the call tonight serve on these panels. And this kind of walks you through what you need to do and how the workup will go. And so I often will, when patients come to my office, I'll have these printed out, and I just walk them through where we are, and I'm able to show them not only what they need to have done, but why they need to have it done. So you start over on the left with the suspicious lesion that's suspicious for skin cancer. There's a biopsy performed, typically again by the dermatologist, and then Merkel cell carcinoma is identified. So again, upon coming to my office, you'll get a complete skin and lymph node exam, and then we'll decide if we need other imaging studies. We'll typically talk about you in one of our multidisciplinary panels. And, one of the things that we do often overlook, but I think it's a really important point, is that for patients who are immunosuppressed, in other words, who are on immunosuppressant medications for a number of different reasons, but including for transplants, we try to minimize the amount of immunosuppression going into any curative treatment. For patients who are what we call clinically node negative or N0, next slide. There's two things that need to happen in the operating room. We take you to the operating room. One is kind of the easy thing. That's the one on the top. The excision with a 1 to 2 centimeter margin of normal skin. Sometimes Mohs can be done in these cases, but often the patients will see us because not only do you need to do that wide excision, and Dr. Steppen showed you some nice examples of wide excisions, you need to perform what's called a sentinel lymph node biopsy. And the sentinel lymph node biopsy is really what's going to drive not only prognosis, but treatment in these cases. So again, for the top part, you are typically excised with a 1 to 2 centimeter margin. If the margins are clear, we often will observe you. If the margins are close or positive, then radiation might be considered because Merkel cell carcinoma has been known to recur not only distantly, but locally. And I think Dr. Thomas is going to give us a little update on radiation in Merkel cells, so I won't steal her thunder. And then the sentinel node biopsy is performed. And again, what that tries to do is really separate people who are low risk and node negative from much more high risk or node positive. And again, if the sentinel node is positive, we bring you back from additional consultation with our multidisciplinary group. And occasionally we'll do radiation to the nodal basin. That's probably the most common thing we'll do. But sometimes we'll do a node dissection. And then if you're sentinel node negative, you're probably just going to get observed. Next slide. So this is just some pictures of what we call a sentinel lymph node biopsy. And the concept of a sentinel lymph node biopsy, you kind of guess by the first word sentinel, is that if you can identify the first node that drains a specific piece of skin, and so for this case, a lesion on the arm, then you can accurately predict the status of the whole nodal basin. So instead of having to take out all the lymph nodes from a particular patient's armpit or groin area or neck, we can use this minimally invasive technique. I typically use two identification techniques. One is a radioactive dye, technetium, which the technicians in nuclear medicine will inject for us. The second is a blue dye, which we inject in the operating room. And you can see us harvesting a node from the groin area on the left, which will then send off for special testing. Next slide, please. Next slide. Oops, nope, I think we went too quick. I went too fast there. All right, I think that's where we want to be. Okay, so, oh, no, there we go. All right, let's stop there. So why is it important to get a sentinel lymph node biopsy? Why do it? Do sentinel node biopsies cure people? The answer is no. But again, if you look at the bottom there, if you're sentinel node positive, your 5-year survival might be only 50 to 60%. Whereas if you're sentinel node negative, it can be upwards of 60 to 80%. And again, for these people who are at very high risk for recurrence and a poor outcome from Merkel cell carcinoma, again, multidisciplinary consultation is key. Radiation is often used. And I think you'll hear from my colleague, Dr. Sossman, we now have medical therapies that we give patients like this in not only the metastatic setting, but sometimes even in the adjuvant setting. So next slide. I think that's all I have. We'll save questions again, I think, to the end of the 3 speakers for this this part. And I hope I've teed up my colleagues, Dr. Tarita Thomas from Radiation Oncology and Jeff Sossman from Medical Oncology, to give us all their wisdom when it comes to using radiation and medical therapies in Merkel cell carcinoma. So Dr. Thomas, you're up first.
Thank you, Dr. Wayne, and thank you all for the opportunity to speak a little bit about radiation therapy. I'll just wait for my slides. Thank you. We can shift to the next slide. I'm just going to give a little bit of an overview. We've heard some really excellent talks about basal cell squamous cell. Radiation therapy can be used for those diseases as well as Merkel cell, which I'm going to speak about towards the end of this section. I'm going to give a bit of an overview of radiation in terms of what is radiation therapy, how does it work, what are types of radiation therapy you might encounter as part of your treatment, and what's really involved in getting radiation therapy, and then speak about a particular case that I was involved in. Next slide. And next slide, please. So in terms of radiation therapy is used in about 2/3 of cancers. These cancers that we're talking about tonight, as well as other types of cancers that can happen anywhere in your body. We use radiation either in the definitive treatment, so meaning as the primary treatment sometimes for small basal cell squamous cells before surgery or after surgery, which is most commonly the case in Merkel cell carcinoma. Radiation therapy is also used to help relieve symptoms. And radiation is an energy. I'm going to talk a little bit about that in the next few slides. We can also treat some benign conditions with radiation, such as osteoarthritis, plantar fasciitis, ventricular tachycardia. Next slide. So the question is, how does you can move on. How does this energy work, okay? And what is radiation? Radiation, when you hear that term many times, it can bring different things to mind. Sometimes I just had a patient today say, oh, I thought I would turn into the Incredible Hulk, or, some of the other things that we've witnessed in terms of in society. But radiation is just really an energy source. And energy can come in many different forms. Here's just a pictorial picture of the different types of energy that we encounter from day to day in our daily lives, apart from therapeutic radiation. So we have radio waves, microwaves that we all most likely commonly use, visible, X-rays, UV light, and gamma rays. And then you can think about the size of these particles of energy. Radio waves can be thought of as big as a building. X-rays as small as an atom. So these are really small packets of energy that help to treat cancer. Next slide. And this is the main therapeutic machine that we use. This is called a linear accelerator. So this is a way for us to accelerate electrons to then either cause production of a photon energy source or an electron source that we can use for treatment for things like Merkel cell, basal cell, squamous cell, etc. Next slide. In terms of energy, we have other forms of energy that you may have heard about on either the news or through your own research, including proton energy. Proton energy is a source that we have here at Northwestern in one of our sister hospitals at Central DuPage Hospital that can be used for other types of cancers and rarely, though, in terms of skin cancers. Next slide. Another way to give this type of energy is using MR imaging. So we have an MR machine that can help us image what we need to treat and help us see it better. So, if a patient has metastatic disease, meaning Merkel cell cancer that spread somewhere else, in this case in the liver with the arrow on the red, we can see that a lot much more sharper with an MRI image than with a CT image. Next slide. So how does radiation work? What do these packets of energy really do? Well, radiation causes breaks in DNA of cells that can lead to cell death. And so we know we want to kill tumor cells and we want to preserve normal tissue. And so this is where the radiobiology concept comes in terms of really causing lethal damage versus sublethal damage. Similarly to treatments, as Dr. Chandra has spoken about in terms of medical oncology management, where we're really trying to affect the tumor and preserve normal tissue. Next slide. Types of radiation I've already spoken about in terms of X-rays, gamma rays, electrons, and we also have other ways to use these energy packets, like carbon atoms, like cobalt, which we use to treat sometimes patients who have brain metastasis coming from tumors like Merkel cell, sometimes like squamous cell, and other types of cancers. Next slide. In terms of delivery of radiation, I think this is a really important thing to talk about. We have many ways to sculpt the dose of energy to whatever part of the body what we want to conform to. So for example, if we're trying to treat a tumor that was on the nose, we can conform to the edge of the nares, the part of the nose that we're breathing out of, okay? If we need to treat somewhere along the jawline, or somewhere along the arm, which happens many times when we're treating our patients with Merkel cell carcinoma. So these terms here are things that you might encounter as you read more about radiation therapy, including intensity modulated radiation therapy. I'll show a slide of that down the road. Go back, please. Okay, and go forward one slide. Thank you. So the role of radiation treatment in Merkel cell carcinoma, Dr. Wayne really set up this talk really in a great way. The majority of time in terms of Merkel cell, we're being asked to see a patient after surgery. So if a patient has had a great resection of the tumor and also has had a sentinel node biopsy, if there are cancer cells in that sentinel node biopsy, we can come in and treat that whole nodal basin. So where that lymph node drains to with radiation to help sterilize where that tumor was. There are other risk factors in terms of needing radiation after surgery. Dr. Steffen spoke a little bit about that in her talk as well. Those include size of the tumor, immunosuppression, location, close or positive margins, and lymphovascular invasion, where there's invasion of some of the dermal lymphatics along where the tumor lies. If a patient is not a surgical candidate, if their disease is unresectable, okay, or if the surgery can cause significant side effects, then we can also think about radiation in a palliative manner to address symptoms of the tumor or try to improve the control of the tumor if it can't be resected. Next slide. So what is involved in receiving radiation therapy? As Dr. Wayne mentioned, we have a very robust interdisciplinary discussion about all our patients who need this type of treatment. And based upon those discussions, if there's a need for adjuvant radiation, meaning after surgery, or if the patient is not a surgical candidate, then they would come to me for a consultation where we would discuss the role of radiation. We'd talk about the planning and the behind the scenes, what happens in terms of getting that complex radiation plan to you. And so this is just a pictorial view of a patient lying down with the different beams of energy coming from different directions to really sculpt around the tumor we need to treat. Next slide. So after the consultation, we then have the radiation planning session. And that's a really important part of the journey through radiation treatment. That's where we really have to create an immobilization for you as the patient to keep you in the most comfortable position in a very uncomfortable situation. So in this case, what you see is a patient lying flat on the table. And here we're most likely addressing a tumor in the thorax, meaning in the lung. And you can see the mobilization device down below. And we need this for consistency, reproducibility, and comfort as a patient undergoes treatment. Next slide. And after the planning session, then a lot of the hard work begins with our team, including PhD level physicists, dosimetrists, therapists. So we all work together, including the physician, to identify the tumor, decide on the dose that needs to go. We already know the dose, but the dose that needs to go to the surrounding areas to preserve the organs in the area where we need to treat. And then before any radiation plan comes to you, we always have a phantom. So that's what you see in the top right, where there's what we would call a phantom, or a fake patient, quote unquote, and we would deliver that treatment to that and verify a lot of quality steps before it comes to the patient, as down below, where there'll be 3 people called therapists who help get you on the table as comfortably as possible, again, in an uncomfortable situation, to get you this treatment. Next slide. This is a patient that was treated who unfortunately had a tumor, a Merkel cell tumor of her elbow. And so she had neoadjuvant therapy, as Dr. Chandra mentioned, that can happen in some of these very complex cases. of pembrolizumab and had actually an excellent response. And then she had a really thorough surgery with Dr. Wayne, and then she came to me for adjuvant radiation due to one of her lymph nodes having disease. And so what you see is her setup here, this cushion that we create around her arm, and immobilization, especially for these tumors that, as Dr. Wayne said, are very rare, really have the best support from a tertiary center that sees a good amount of these cases to really have the expertise for this part of the treatment. The setup is actually very important. And then what you see on the right is the dose that we're trying to deliver to the area from the elbow up through the arm and into the draining lymphatics. And so you see that with the yellow line surrounding the area we want to see in purple. Next slide. So thank you for the opportunity to speak, and please feel free to connect if there are any questions. Thanks.
All right, Tarita, that was really another just fabulous talk. It just amazes me what my partners and do, seemingly across the same campus on any given day. So next, it's really going to be really an honor and a pleasure for me to introduce to you Dr. Jeff Sossman, who's really been one of the fathers of immunotherapy and advanced treatments for patients with skin cancers in this country. And Jeff's been a trusted partner over many, many years. And we're really lucky to have had him as a partner here. And Jeff, you're going to talk to us a little bit about medical therapies for Merkel cell, and we're really looking forward to your talk. Thank you.
Elson, you have my slides? Okay. Can everyone hear me?
Yes, we can, Jeff.
I never know. Okay, so what I'm going to try to do is fill in and give you a little background about the systemic therapy. In other words, the therapy that we give, which should treat all the tumor that's there, all the Merkel cell in the primary or the metastatic sites. Okay, let me see. Okay, so I think all of this has been discussed already about Merkel cell and its increase and its link to a virus, and certainly its link to patients who are immune suppressed. Okay, next slide. Okay, next slide. Okay, I think might have been mentioned, but many of these tumors actually have evidence of virus associated with them. It turns out that this virus is fairly common, or actually very common. And so a lot of people do have evidence. But we've seen over time how clear this virus and the immune response to it is really a clue of both the presence of the Merkel cell tumor and even could be a factor in monitoring therapy as well. Next slide. Okay, so in this very blurry slide, it's sort of indicative of the way therapy of Merkel cell tumor cancer has gone. Up until, I would say, the last 5 to 10 years, it was dominantly or almost entirely treated with chemotherapy. And certainly, while the chemotherapy did have some benefit, it was short-term, and you can see nearly all patients had died by 3 years. Now that's been completely changed with the presence and evolution of immune therapy in this disease. And you can see now they're at least 60% who are alive at 3 years, and a much smaller patient population who has progressed and passed. I think this is really a good indicator of how the improvement of survival is really linked to the change in therapy. Next slide. Okay, why don't you go to the next slide? Okay, so right now, the standard treatment of Merkel cell tumor is one of these anti-PD-1 antibodies, and two have been approved. One is pembrolizumab, which is one of the anti-PD-1 antibodies, and avelumab, which is an anti-PD-L1 antibody. And while we've had great improvement in therapy in terms of survival, we still see a lot of patients who ultimately progress and have refractory disease and certainly need other treatments. So what's happened is there's been really a search for other therapies that could enhance the treatment. And you can see there are drugs like lenvatinib, which is an oral drug that has some activity, or a drug which is combined with nivolumab or Opdivo, relatlimab. And again, in melanoma, that has shown a benefit. And as I said, a standard treatment is really anti-PD-1 or Keytruda, pembrolizumab. I'm going to talk about some other approaches that are all investigational, and CAR T cells is one of them, but these are all ways that we're trying to improve the outcome. Lastly, and quite important, is the presence, development of Merkel cell cancer, just like squamous cancer, in patients with organ transplant, kidney, liver, heart, and these patients who are immune suppressed, in a way to continue to keep the organ alive, definitely sets up a situation where tumors like Merkel cell can progress and be very metastatic. And so that's an area where there's been a lot of questions about how we can do it. Activating the immune response is certainly an approach that's fraught with real toxicity in a patient who has a transplant and may lose their kidney transplant or other. Next slide. Okay, so first I wanted, and you've heard actually a few times, maybe to every talk that's been given about neoadjuvant therapy. And I want to, it's relevant to Merkel cell as well as certainly some of the other skin cancers. And really, the standard treatment of patients has been to do surgery to a lymph node or even a metastatic site, and then give them treatment. And those arrows are really the pembrolizumab or the avelumab. And in that case, you do get, in the blue are small cells that infiltrate around the tumor. But you can see if we treat patients on the bottom with the tumor in place, it allows for a much more vigorous immune response. And you can see that by the second picture. And so when we remove those tumors, actually, sometimes we don't even see any viable alive tumor. And then we set up a situation where immune cells are there in abundance. So this has proven not to be just a theory, but actually really a very important concept to all of these skin cancers. Next slide. Okay, on the right, I just wanted to show that, and this is a little, on the right, you can see that these are all your immune cells and how they expand. And on the right, you can see the expansion of immune cells that were present to begin with, as well as additional immune cells that develop with treatment. And you can see how more vigorous that response is. And that sort of exemplifies how neoadjuvant therapy works. It's not simply decreasing the amount of tumor. It's not simply making the surgery, but it's also easier.
You didn't have a headache that did you?
Next slide.
You have a candy bar?
No.
You want some nuts?
No.
Why don't you go to the next slide? Murata, next slide. Okay, so I wanted to also sort of talk about where is the field going? How are we improving treatment? And I'll show you a few examples. These are all in clinical trials, which, as I've said before, and we've all said, are so critical in moving the field forward, and that's true with Merkel cell as well. There's an approach that looks at giving radioactive antibodies that are linked, and they're linked to a receptor that actually you see on neuroendocrine tumors. And there's an attempt now to try to use this Lu-177 in combination with pembrolizumab or avelumab. And those are certainly efforts taking place now. Another approach, which I'll show pictures of, is KRT-232. And this drug actually inhibits a molecule called MDM2. And what MDM2 does is it actually indirectly protects the tumor from being killed from whatever it's being treated with. So if that can be knocked down, then certainly it's possible that will improve therapy with either of those drugs. And thirdly, there's an approach using tuvusertib, which is an inhibitor of DNA repair. So DNA damage is really a frequent byproduct, an important product of therapy, whether it be chemotherapy or even immune therapy. And it can be combined with immune therapy and potentially be more effective. Lastly, there's even an attempt to combine multiple checkpoint inhibitors that don't just bind to anti-PD-1, but they can bind to some of the other receptors, and certainly could potentially be much better than the single drug. Most of these are now being tested in the second line, so mostly in patients who have gotten the initial anti-PD-1, likely had a response or didn't have a response and recurred. And this is certainly an area of huge medical need. And if these studies look positive, then certainly patients will start studying these drugs in the front line. Next slide. Okay, and this is just an example of how this radioactive isotope is bound to a molecule, which then is bound to this acryotate, and it's the acryotate that carries the radioactive tumor into the cell itself. And again, causing DNA damage and combining it with immune therapy. Next slide. Okay, this is a busy slide, but in the left upper corner, it shows you in a way the way that MDM2 works. There are all these other mechanisms that are being looked at in various cancers and that don't include MDM2, but lead to death of cells or growth arrest. And what MDM2 does is it actually inhibits the breakdown of some of the cytotoxic agents that are in the body. So in a tumor that doesn't have p53, this is especially important because its ability to inhibit these other molecules that actually allow the cancer to recover from therapy. And that's kind of its place. Next slide. And then lastly, the tuvusertib is in a way similar. It binds to a DNA repair. So when DNA gets damaged directly, this drug helps repair it and prevents repair, not helps, but prevents repair in a tumor cell, leading to cell death. So these are all ways to approach this. Next slide. And then this is just mentioning the triple therapy, which is really just meant to enhance the one treatment. Next slide. And this is a really busy slide, but what I wanted to highlight is there have been, I believe they're both closed, adjuvant therapies. So patients who undergo primary therapy with either surgery alone or surgery and radiation, we're looking to try to find ways to prevent recurrence. And there have been two clinical trials that have been actually have completed accrual, but we're really anxiously awaiting. And one is using avelumab in a patient group of high risk, and the other is using pembrolizumab. Next slide. So I think this pretty much covers. I talked a little bit about neoadjuvant, and then lastly, adjuvant. The effort to combine therapy with new drugs, and we talked about testing in the blood, and this might be a role to allow us to better monitor patients for recurrence and even for efficacy of the treatment. And then transplant studies that certainly are needed in the organ transplant group. Next slide. So I think I've certainly summarized all of this. I think that there's no question there's been a huge breakthrough with immune therapy, but there's still a lot to be done and a lot that needs to be studied. And you saw adjuvant therapy, hopefully we'll see a breakthrough there. And then the use of neoadjuvant early immune therapy, and then finally looking at new agents to combine with PD-1, which we have already. Next slide. And thank you all. Thanks the AIM Foundation for allowing us to present this to you. That's it.
You are muted, Jeffrey.
Okay.
Jeff, I think you're muted.
Oh, sorry. Sorry. To keep us on time, and it's getting late in the hour, I'm going to just roll right into Dr. Chandra's next talk on clinical trials in non-melanoma skin cancers. It actually may answer one of the questions, at least, that's in the chat. And then we'll wrap up things after that with a little question and answer period, and finally a case presentation. So Sue, why don't you go ahead and get us started?
Thanks, Jeff. So I think Dr. Sossman, Jeff, you set me up kind of rather well to talk about clinical trials. So I wanted to kind of take a 30,000-foot view and discuss why and how clinical trials are set up. Most of the drugs, most of the systemic therapies that we have discussed have all led to approval by the FDA because of people just like you participating in clinical trials. So we wanted to take some time to kind of discuss and hopefully debunk some myths of clinical trials. Next slide, please. So today I'll be talking about what the pathway is for these cancer drug developments, the different phases of clinical trials, and how really at this day and age, it's the only way that leads to new and improved standards of therapy. In the past, drugs could be grandfathered in, but no longer. Now we have to be able to prove their effectiveness and their safety. Next, I'll talk about why placebo-controlled trials may be appropriate in certain settings, and then what are some present and future trials currently occurring in these non-melanoma skin cancers, of which Jeff alluded to quite a few of them. Next slide, please. So if we think about cancer drug development, first of all, thousands of compounds are often reviewed, depicted in blue, to kind of figure out what may be promising in a particular cancer subtype. Then preclinical or laboratory studies take a very small number of that and actually do some testing to see in a laboratory dish, does this work? And potentially in animal models, does this work? And then even fewer number of those, if you look at the middle column in the greens, even fewer number of the original compounds make it to an actual clinical trial. Now, if you look at phase 1 versus phase 2 versus phase 3, the number of participants generally differ because the endpoints or the objectives in each of those phase trials are a little bit distinct and are very statistically based. And then finally, if a trial goes through phase 1, 2, and 3, then it can lead to an FDA-approved drug. And even in the post-FDA-approved setting, we are often asked to report safety data just to make sure that this drug that is now FDA-approved doesn't show some new unexpected safety concerns. Next slide, please. So these are the phases of a clinical trial. So preclinical, this is all done in the laboratory. There's, scientists all over the world working in laboratories trying to understand if a particular compound or drug is effective in the laboratory and in animal models. Next, it goes to a phase 1 setting. So in phase 1, That's where we involve patients. And the primary endpoint or objective in a phase 1 study is always safety. We might look at whether there's a signal of activity or efficacy or effectiveness, but the primary question is first, do no harm. Is this a safe compound for the person for us to explore further? Next is phase 2. So here we're not only still looking at safety, safety really never goes away, but now we're looking at dosing. What is the right proper dosing that leads to the most effective shrinkage of tumor for many people? And some other endpoints could be the period of time in which there's no tumor growth. So that's usually a phase 2 study. Now, the gold standard is a phase 3 study. So this is looking at that original drug question and compare to the standard control. And so here, not only are we looking at safety, but we're taking the dose that's been identified in a phase 2 trial and studying it in the phase 3 trial to see, again, are there any new safety signals? And number 2, is this an efficacious or effective cancer treatment? Then that data is presented to the FDA, and the FDA makes their decision of whether something is approved for us to be able to treat our patients. And then after approval, like I said, there's continuous safety and as well as efficacy monitoring. Next slide, please. So as Dr. Salzman had alluded to, right now we're really looking at 3 settings of treatment in medical oncology, as well as my other multidisciplinary colleagues. So we're looking at pre-surgical or neoadjuvant clinical trials. We're looking at post-surgical or adjuvant clinical trials. And then we're looking at patients who have unresectable, means they cannot undergo more surgery, or metastatic disease. And we're looking at clinical trials for them. Next slide, please. So I'd like to spend a moment talking about this cancer immunity cycle, where here, one more click, Elson. Here we look at basically ways to augment our natural immune system. So basically we have a tumor. The tumor is acted upon by our natural immune cells in an indiscriminate, what we call antigen independent manner that basically chops up the tumor. It spills a lot of tumor pieces or neoantigens depicted in these little red dots. Those are then picked up by the antigen presenting cell shown in green. That antigen presenting cell shows those red dots or those neoantigens to T cells. T cells are our soldier immune cells. They then basically travel through the blood vessels back into the tumor microenvironment, and that T cell can then identify that tumor cell and hopefully kill it. And we have developed, we meaning the medical and scientific community, have developed various modalities shown here in blue and red that augments this natural cycle. And the things depicted in red are what we've kind of focused on so far in our discussion. With one additional that should have been in red is the anti-PD ligand one, avelumab, that Dr. Salzman talked about in Merkel Cell Carcinoma. Next slide, please. So these are the approved, these are the FDA-approved drugs in these 3 non-melanoma skin cancers that we've already kind of covered. Next slide, please. So the question really is, how can we improve upon those? So can we look at the pathology a little bit deeper and figure out who would benefit from what drug? Could we think about biomarkers to help us stratify who would respond better to a particular drug compared to someone else, who might have increased or lower risk with particular drugs? Again, looking at these in earlier, both neoadjuvant and adjuvant settings, not waiting until metastatic disease develops. And then in general, when someone develops metastatic disease, our general paradigm of treatment now has been immunotherapy plus drug X. And that drug X can be really one of many drugs that have shown to have some promise in these non-melanoma skin cancers. There's also intratumoral. These are basically injections that we can inject drug directly into the tumor. We can use trials where we're adding a drug on chemotherapy or cetuximab backbone. And then we're also looking at trials for special populations, such as those who are immunocompromised from a solid organ transplant, for example. Next slide, please. So I briefly talked about neoadjuvant, as did Dr. Sossman. And again, the reason I bring this up is because this has now been quite established in melanoma, and it's really being looked at in non-melanoma skin cancers. So again, the whole point of this is that if we remove the tumor, then treat with immunotherapy, that immunotherapy really has no tumor cells to identify and act upon. Versus if we leave the tumor in place, then give immunotherapy, it can actually lead to more tumor shrinkage. And then eventually that tumor is then removed by our surgeons. And then the overall outcome may be better. There might be more immune cells doing it in the neoadjuvant setting. Next slide. So although neoadjuvant therapy has been really only studied robustly in melanoma, I think this is now going to be the new paradigm that we're going to move towards in non-melanoma skin cancers. But it's going to have to be usually in the setting of a clinical trial, because this is not yet approved. So what do I mean by a neoadjuvant trial? So this is melanoma. Please take that into consideration, but it would look something similar to this. So in melanoma, we took patients who had visibly apparent nodes on radiographic or CT, MRI, PET scans, or palpable or feelable nodes. They were randomized to going straight to surgery and then receiving post-surgical or adjuvant immunotherapy. That was one arm. The second arm, they got immunotherapy for a few cycles ahead of time. Then they were taken to surgery, and then they got more adjuvant post-surgical immunotherapy. And here, we don't have to be a statistician to see that those who got neoadjuvant first, depicted in blue, had a much better probability of survival. This curve is much higher than those who went straight to surgery. Now, again, this is not yet approved in It's not yet completely standard in melanoma, and it's certainly not yet standard in non-melanoma skin cancer. But this is an example of a clinical trial that we're looking at in non-melanomas as well. Next slide, please. So this is, again, if we take the notion of giving neoadjuvant or pre-surgical immunotherapy, this data shows that when you do that and you look, and then the patient then goes to surgery, and then the surgeon takes out that treated specimen, those who have 0 viable or living cancer cells in that treated specimen, depicted here in green, have a significantly higher survival. So this kind of shows you that those who have had a major, what we call a major pathologic response, meaning the neoadjuvant therapy really shrunk their tumor, so much so that we can barely find any living cancer cells, they're the ones who survive the most. So again, showing you that a neoadjuvant approach is probably something that we really need to consider on a trial for non-melanoma skin cancers. Next slide, please. So I'm not going to go into this in great detail, and you certainly don't have to memorize this, but I just wanted to kind of show a snapshot of trials that we have in our non-melanoma skin cancer portfolio. The ones in purple are ones that we have here at Northwestern, and then there are some other ones that I thought would be worth mentioning that are across the country and sometimes the world. In a nutshell, next slide, please. I think it's really important to know that so far, one more click, Elson, we've really only talked about anti-PD-1 antibodies in great detail, but think of all of these targets on a T cell or all of these targets on an antigen-presenting cell or dendritic cell that are just really waiting for us to explore in the non-melanoma skin cancer world. So next slide, please. I wanted to encourage all of you, and just in general, we always try to encourage our patients to consider a clinical trial when and if appropriate. It's essential for newer and better therapies to be approved. And in the world of non-melanoma skin cancer, we really need these clinical trials in order to move the field further and in order to be able to offer all of you better therapies. Next slide, please. I just wanted to say that clinical trial participation really depends on and certainly all of us to be aware of what's out there and be able to appropriately discuss it with you and hopefully alleviate any concerns and answer any questions that people may have so that they can make an informed decision of whether a clinical trial is right for them. Thanks so much.
Okay, Sue, thank you for all that information. You know, we really just have a few minutes left before the top of the hour. So I think what we're going to do, I'd like to invite all my panelists to turn their cameras on. We have a number of questions in the chat. I think we'll just go to those. And then Anne from AIM at Melanoma wants to talk to you a little bit about their website. So, but why don't we go ahead and clear the questions. So the first one I'm going to use, Jeff, I don't know if you or Sue wants to take this one. At Northwestern, are you using any patient genetic vaccine treatment in the medical oncology if medical oncology treatments fail?
That's a great question. So in general, in the metastatic skin cancer setting, vaccine trials haven't really shown to be efficacious despite numerous trials, especially in melanoma. You may have been alluding to a vaccine trial that's being looked at in melanoma in the adjuvant or post-surgical setting, in which case that person has gotten their melanoma removed and now is getting a vaccine and immunotherapy to try to prevent melanoma from coming back. That mRNA vaccine and pembrolizumab data, the phase 2 trial looked very promising. Phase 3 is ongoing. But in general, in the metastatic setting, vaccine trials haven't really shown to be efficacious or effective thus far.
Thanks, Sue. Lou, this one's for you. My mom and I are listening together. She has been diagnosed with basal cell carcinoma. Does this mean that my siblings and I are now at greater risk for any or all forms of skin cancer?
And that's a great question. And, you know, so a family history of a basal cell skin cancer will increase your risk of non-melanoma skin cancer, so basal cells and squamous cells. The amount of that, there's some papers that there's a variety of data that you might see about how much it increases, and part of it is probably, you know, if you have a family member who had a basal cell and they have fair skin and you have fair skin, you're at an increased risk of, you know, a non-melanoma skin cancer like basal cell or cutaneous squamous cell, just from that alone. But some studies have controlled for that risk and shown there's having a family member with a skin cancer will increase your risk of basal cell and squamous cell.
Great. Next question. I have an autoimmune condition and Merkel cell carcinoma. What therapies are available for individuals with a compromised immune system? I don't know, Jeff, do you want to take that one or?
Well, I think, you know, I think you had mentioned autoimmunity as opposed to transplant. And we certainly see varying degrees of colon inflammatory disease, Crohn's disease or inflammatory bowel disease or autoimmune disease elsewhere. Obviously, patients doctors need to be more cautious. But I think the one thing, it's a misnomer to think that all of those patients are completely excluded from getting immune therapy. I think if the balance of the pros and the cons, favor the importance of giving that therapy, I think patients should get immune therapy. And most of the studies that have been looked at show that the toxicity is a little greater, but patients can be managed and can get through it and have a good response. So I think we're learning more about these patients, but I think one thing you can say is there are no absolutes. Not somebody like that who has autoimmune disease and we think it will flare. That person can still get therapy depending on the benefit.
Okay, great. Next question. I don't know if Lou, you want to take this one, or Murad, if you're on. After Mohs surgery, is the choice for healing applying Vaseline to the wound? Is there anything else to heal that is not greasy?
Yeah, you don't have to use Vaseline. There are other things you could use. You could use something less greasy. Vaseline or something like Aquaphor healing ointment is useful in the first few days when the wounds are more likely to scab. You don't want that to happen. But after that, even if you want to use antibiotic ointment, that's fine. And just a thin layer is sufficient.
Okay, next question. And I don't know if Caitlin, you want to take this one, or Sue, or I can talk a little bit about this. Are there tests to help detect early recurrence of Merkel cell carcinoma?
I'd be happy to put my 2 cents in. I mean, so scans are probably the gold standard, I would say, to detect macroscopic or visible disease. There are some tools that we have where we can look for Merkel in the blood. Those who are polyomavirus positive, we look for antibody titers, antibody levels against components of the virus that might be floating in the blood. That's one. The other is certain institutions are participating in a consortium where we're actually checking for Merkel tumor DNA in the blood. The problem is we got to take all of it into account before we say that someone has Merkel recurrence. The gold standard is still the radiographic imaging. If those laboratory tests are significantly elevated, we may decide to do the scans a little bit sooner.
All right. Next question. Are there things that patients can do to decrease the side effects of these treatments? I don't know. Lou, you want to talk
Jeff, I
about
think you're on mute.
Oh, no, I don't think so.
Other Jeff.
Oh.
That's really an area of great evaluation and studies. And at this point, it's not obvious that there are things. I think the most important thing is to note and tell your physician when you even have very early side effects, whether they're even rash or whether they're colitis, inflammatory bowel symptoms with diarrhea and pain or shortness of breath. I think the best thing we have as of right now is the use of early detection. Now, there are some studies ongoing now looking at some of the same agents used for rheumatoid arthritis or something, autoimmune disease, and none of those yet have been determined to be effective enough to use it preventively.
Okay, we have 2 questions left, and then I promised Anne she would have some time to talk to you all about the AIM website. So with all the different trials, how does someone know which one to participate in?
That's a really great question. I mean, I think, we hope that our job allows us to really offer you, allows us to really discuss different trials, what pros and cons of each trial may be. Perhaps your doctor can share with you what their personal opinion might be about a particular trial's potential effectiveness or safety. But certainly ultimately the decision is really up to you. Our hope is, though, that we can help answer your questions and alleviate your concerns. So at the end of the day, you, along with your loved ones, can make the right decision for you. But we certainly don't expect you to be able to know that answer off the get-go. And that's why hopefully your medical team is there to help you.
But I'd add, it's really especially important is when you're enrolling on a trial where there is established therapy, and that established therapy is going to be compared to that plus something else or something different. That's really the only way we're going to move those treatments forward. And the fact that we have therapies now give us, there's no placebo controls. Everybody's going to get a treatment in the future, at least.
Okay, and our final question we'll take tonight is, are you at Northwestern evaluating ways to improve prevention of skin cancer? For example, I understand that AKs are precursors to SCC. Are there any new therapies and or medications being evaluated to prevent AK growth and or remove cumulative actinic damage? Lou, do you want to take that one, or Murad?
Yeah, I can comment on I think we're always thinking about ways we can do both of those things. So there's people have been looking into medications or supplements that one can take to reduce the incidence of, or the chance that likelihood that you develop more skin cancers in the future. As far as actinic keratoses and squamous cells go in particular, I'll just touch on one relatively newer compounded topical medication that we've been using. So in the past, if you have a lot of these precancerous actinic keratoses, you might have heard about Effudex or used Effudex or fluorouracil, which is a topical chemotherapy cream that basically kills all the precancerous cells, causes a lot of redness, inflammation, pain. And recently we've found that compounding this topical with casapotriene, which is a vitamin D analog, seems to recruit your immune system to help essentially have your body recognize these changes. And so we're able to do this instead of twice a day for 2 weeks with the compounded medication. We can do it twice a day for 4 to 5 days. So it's much easier to use. It seems to be better tolerated, and it seems to reduce your likelihood of developing actinic keratoses, squamous cell carcinomas in the areas that you've treated it going forward.
Great, thank you, Lou. All right, so with that, I'm going to turn things back over to Ann Garst-Taylor, who's our gracious host from AIM, and she's going to talk to you a little bit about AIM's website. On behalf of the entire Northwestern faculty that participate tonight, I wanted to thank you all for your attention and for spending a couple hours with us on this Tuesday night. So thank you, everyone. Ann?
Yes, and thank you. I know that we're at the top of the hour, and thank you for giving me just a minute of your time to talk to you about our new website, AIM at Skin Cancer. As I said, AIM at Melanoma is the parent organization of this new website that we opened in January. We've built a website with educational information that covers all kinds of facets of the various forms of non-melanoma skin cancer. We did that because we believe that well-informed patients make better choices for their care. Beyond a doubt, the most frequently visited pages over the last 6 months have been on diagnosis, staging, treatment options, and side effect management. I encourage you to go and see those sections. But in addition, I wanted to point out a few sections that I think are also very important and useful. One is our image library. We have over 100 images, including 50 that are on individuals who are people of color. So please visit that image library. We also have a section that's dedicated to caregivers. We know caregivers are instrumental in making choices about care. And so we'd like to offer guidance on how they can best support the patient in their life. We have a service that's called Ask a Cancer excuse me, Ask a Skin Cancer Nurse. Krista Rubin is an oncology nurse with 30 years experience, and she will offer free and confidential advice on questions that you may have that will help you to understand the treatment that your care team is suggesting for you. And finally, we have a media library, which we are adding new videos to every single week, and including today. We will take tonight's symposium, we'll divide these topics up, edit them, and put them back on our website so that you can watch them again and again. So if you have any questions, if I can guide you to anything on this website, please contact me, and I will put my contact information into the chat. And with that, I also will thank everyone who joined us this evening. Thank you so much, and have a good evening. Good night.
Good night, everyone. Thank you.